Obviously, electrolyte balance is necessary for homeostasis. Your nursing role is obviously in terms of, I have to find out if you actually get a grade at the end of the exam, because I also have to do a review of the questions to see, how many people got wrong, which question they got wrong, and if anything needs to be thrown out. I don't know that you'll find out results at the end of the exam. I'll double check that. So in terms of fluid and electrolyte balance, you're looking at obviously maintaining homeostasis, and you need to look at what imbalances may exist. 60% of your adult body is fluid, and it's going to vary with age, body size, and gender. The younger individual, the infant, the young child, they have a higher percentage of water because they have an increased metabolic rate. Whereas an older, more geriatric population has a lower fluid status because of the fact their metabolic rate has diminished. In terms of intracellular and extracellular fluid, intracellular, you're looking at skeletal muscle mass, etc. Extracellular fluid actually breaks into two components: intravascular and interstitial. Intravascular is within the vascular bed, as you can probably guess, and interstitial is in the tissue bed itself. So when you're looking at the two compartments that you see fluids in, intracellular, which is inside the cell, obviously, and muscle mass contains a strong amount of that, and extracellular is subdivided into two parts, intravascular as well as interstitial. Interstitial is also generally known as third spacing. So when you hear people talk about third spacing in the clinical area, they're talking about fluid that has gone into the interstitial space. There's also what they call transcellular, which would be like cerebrospinal fluid, which would be cerebrospinal fluid, pericardial fluid, as well as synovial fluid. But primarily what you're looking at in extravascular and extracellular is intravascular as well as interstitial. Now, in terms of electrolytes, you're looking at charges of positively charged is cation, negatively charged is anion. So I always remember cations because T plus positive, and then anions. So your major cations are your sodium, your potassium, calcium, magnesium, as well as hydrogen. And your major anions are chloride, bicarb, phosphate, sulfate, and protonate ions. Electrolytes are expressed in terms of milliequivalents, but so especially calcium can also be talked about in terms of milligrams and grams. And then obviously electrolyte concentrations differ in different fluid compartments. The movement of fluid through capillary walls is going to depend on basically two pressures, hydrostatic and osmotic. Hydrostatic pressure is the pressure that's exerted on the walls of the blood vessels, and basically you're looking at water, you're looking at, when you're in terms of IV administration, you're looking at crystalloids. Osmotic pressures are high density molecules that pull fluid towards it. So sorry about this, I don't know why those things are popping up. In terms of osmotic pressure, you're looking at it has a pull to pull fluid. So an example of something that has high osmotic pressure that you'll see it, excuse me, administered in the clinical area, excuse me, is albumin. Albumin is a protein, and it will pull fluid in, and very often when you see a decrease in terms of urine output, one of the issues that may be considered is the fact that the cardiovascular system doesn't have enough volume and that the patient is third spacing, so that they'll administer albumin to pull fluid into the vascular bed so that the kidneys are better perfused, and then you'll see diuresis. So that direction of fluid movement is going to depend on hydrostatic as well as osmotic pressure. So when hydrostatic pressure supersedes osmotic pressure, that's when you get peripheral edema or interstitial edema. Now, osmosis is when you have, there's three concepts to remember when you're looking at, to step out of this a second, in terms of fluid makeup. So that a solute is a particle, solvent is the fluid that the particle is dissolved in, and subsequently the combination of the two is solution. So when you're looking at osmosis, you're looking at an area of low solute concentration moving to an area of high solute concentration. So in essence, trying to balance it out, the fluid trying to equalize it out in terms of concentration. Diffusion is movement of particles from a higher concentration to a lower concentration across semi-permeable membrane. No energy is utilized. Filtration is movement of both water and solutes that occurs from an area of high hydrostatic pressure to an area of low hydrostatic pressure. And when you study the kidneys, you'll see that filtration plays a huge role in terms of how the kidneys function. And then active transport, as seen by the sodium-potassium pump, is actually when energy is utilized. So you're going from a lower concentration to a higher concentration. So subsequently, you're looking at energy utilization. In terms of gains and losses with regards to fluid, obviously you're looking at your intake and output, but what really reflects what your fluid balance is when you do daily weights on a patient. Your intake and output primarily tells you, excuse me, primarily tells you how you got there, all right? But your daily weights tell you what your fluid balance is. And your fluid intake is obviously what you take in with regards to PO intake, but it also, in terms of, excuse me, water, lends itself to what you get from your metabolic component. Remember, CO2 in water is the byproduct of aerobic respiration, so that water production is also absorbed. Your loss is also seen in terms of through your kidneys in terms of urine output, 1 milliliter per kilogram per hour. You also have what we call insensible loss, which comes through your skin. What's not absorbed comes out through your lungs and also your GI tract. So that insensible loss is where you're looking at especially the daily weights. You know, your intake and your output, as seen through your output seen through your kidneys, generally equalizes to each other. But then you have to also consider those insensible losses as well. With the older population, you have to consider that the imbalances may be subtle. If people are dehydrated, they may suffer from delirium. They have decreased cardiac reserve. And as you get older, things start to wear down, so you have reduced renal function. And dehydration is common. And dehydration is common in the older individual, yes, because of what they present with in terms of the aging process, but also in terms of the metabolic process, so you're not building up water, but also there's an incidence of, you may know, of incontinence surrounding an older population. And very often those individuals will not drink as much as they need to because of the awareness of that incontinence. So that you always have to remember that when you're dealing with an older population, an older patient, when you're administering medications, you want to make sure, look at their mucous membranes to see how well they're actually hydrated. And obviously there's age-related thinning of the skin and loss of strength accordingly. In terms of looking at fluid balances, that you're looking at the two things that can go wrong. You can either have too little volume or too much volume. And your deficit can, in terms of fluid volume, can come from losses of water. And remember that when you're looking at fluid, and in terms of looking at clinical presentations, you have to remember that water is something separate than solutions. So water is water. So when you're looking at replacing water, that's exactly what you're going to replace. Okay, normal saline does not replace water. Okay, actually, what would replace water if you were giving it in an IV solution would be D5W, that's dextrose and water. So that what would happen is that insulin would carry off the glucose into the cell, and then you'd have free water available as the body needs. And if you're going to give water PO, you actually have to give water. And we'll talk a little bit about that, excuse me, in terms of supplementation when we talk about sodium. In terms of dehydration, in terms of just losing water, you'll also see concentration of certain electrolytes like sodium. Now, what can add to fluid volume deficit would be vomiting, diarrhea, sweating, GI suctioning, so that not only poor intake, but also those things that would also remove fluid. Third spacing. Third spacing is when the fluid goes in extracellularly into that interstitial space. You'll see it with burns, you'll see it with ascites. So instead of it being in the vascular bed, it's now in the interstitium. So subsequently, patients may still have that volume there, but it's not placed where it should be. And in terms of where you would also see loss would be if you're bleeding with hemorrhage, obviously, diabetes insipidus, which we'll talk about with endocrine, and certain adrenal insufficiency concerns. Fluid volume deficit can happen rapidly, especially with something like hemorrhage, and the severity depends on how much volume is lost. That in terms of nursing, depending on where you are, generally speaking, your intake and output in the critical care setting is calculated on an hourly basis. But you're also looking at it in concert with the end of shift values. And as you well know, that shifts are now most commonly 12 hours. So the idea of looking at it at 8 hours may not really follow suit with regards to how the counting or the looking at intake and output is assessed. And most, if not all, agencies that I know of, intake and output is now done on a data management system, a computer system. So subsequently, hourly assessments is quite possible. You want to watch vital signs. If somebody starts to become hypovolemic, their blood pressure will go down and their heart rate will go up because there's less volume and the body's trying to pump it around. You'll see skin turgor change with regards to it being poor and the mucosa drying out. You'll also see a change in mental status, once again, because of the loss of water in particular, and subsequently the buildup of sodium, which is a CNS depressant. So that you want to have measures to minimize fluid loss, and you want to, administer fluids orally if possible. If not, then you're going to have to administer them parenterally through an IV. Now, fluid volume excess is when there's an expansion of fluid in terms of your extracellular component, and subsequently it's overbearing to the body system. Fluid, what could cause fluid excess would be fluid overload or diminished homeostasis or homeokinetic mechanisms. What can also cause it would be your pump failure, your heart failure, kidney injury, so you're not getting rid of the fluid, and also cirrhosis of the liver, which also lends itself to renal function as well. Contributing factors would be the idea of salt, sodium, and an excessive administration of sodium. The sodium will pull the fluid towards itself. So clinical manifestations of fluid excess would be edema, and generally speaking, that's also associated with right-sided heart failure. You'd also see it with distended neck veins, and you'd also see it with crackles from left-sided heart failure. And that right-sided heart failure would also be seen with that distended neck veins as a symptom. You're going to, in terms of nursing management of fluid excess, same deal. You're going to look at intake and output, daily weights. You're going to look at a response to medications that will remove fluids. And the big drug category is diuretics. And as we spoke about earlier, in earlier classes, that diuretics all remove water. What makes them different is their impact on electrolytes. So loop diuretics like Lasix, looking at, a need to, look at the impact in terms of electrolytes and remove sodium and potassium. And then you have potassium-sparing diuretics, which exchange sodium for potassium. And then you have diuretics that just take off water. But all diuretics take off water, and it would be used as a treatment for fluid excess. You may need to have fluid restrictions, and you may need to have sodium restrictions as well. And then obviously you want to promote rest in order for that balance to be facilitated. Now, in terms of electrolyte, go ahead.
Question.
Go ahead.
Can you also have fluid volume deficit with hypernatremia?
With fluid, the problem with hypernatremia is that it could be from dehydration, so that could be a potential, and you would need to subsequently replace. Sometimes in the clinical area, what you might see in an older population is you might see that, in particular, you might see normal sodium level is 135 to 145.
Right.
So that you'll start to see a creep up of sodium levels, and what you might see ordered is 250 cc's of water every 4 to 6 hours to bring down that sodium level. If you see an order like that, then that means you need to be checking what the sodium level is, because most commonly that's in response to that. Okay. And when you're hypernatremic, it's a CNS depressant. So if you have an older population and you're starting to see their mentation changing and you see their sodium level is high, those two things are generally connected.
Okay.
Yeah. And then, so we'll look at these different, the electrolytes accordingly: sodium, potassium, calcium, magnesium, phosphorus, and chloride.
Okay.
So that, I'm sorry, go ahead.
No, I just said thank you.
Yeah. Oh, okay. No, thank you. Okay, so, we'll first look at hyponatremia. And hyponatremia is a serum sodium that's less than 135. Normal is 135 to 145 milliequivalents. And generally speaking, it's a result of fluid overload in a surgical patient acutely very often, if it occurs. And the thing that you have to remember about surgery is that, there's always a concern about fluid loss and fluid deficit. So the patients, when they come out of surgery, are not, are given a lot of volume in the OR. And you balance that with also what was the estimated blood loss as well. Chronic, loss of sodium has a longer duration, and you need to, it'll be more seen in terms of neurologic changes, so you have to monitor the patient accordingly. Exercise associated is that if you have really high temperature, then you could also have fluid loss as well. And that's why when you're looking at heat exhaustion, as it's commonly called, if a patient is sweating and then they stop sweating, that's a very bad sign, because that means that they're getting severely dehydrated accordingly. So your clinical manifestations of hyponatremia is you're looking at an imbalance of water, and and you're losing water accordingly. You're going to have poor skin turgor. You're going to have dry mucosa, and as you can see, a decrease in blood pressure because you're losing water, you're losing volume. You'll have abdominal cramping, and you'll see neurologic changes. In terms of management, is you got to treat the underlying cause. You may need to replace sodium. You may need to have water restriction. Also, you see this with psych patients sometimes who, have like obsessive compulsive behavior, and they drink a lot of water. Like, I'm talking not just a little bit of water, I'm talking gallons of water. And it's been my experience, in terms of, seeing patients in that type of presentation. You also want to look at the medication, reassess it. Maybe they don't need as much Lasix as they did before. You also want to look at intake and output and look at daily weights accordingly. And you look at sodium intake, make sure their diet is adjusted accordingly. And like I said, look at the types of medications that they are on that could affect fluid balance. Hypernatremia is seen as a sodium level greater than 145 milliequivalents per liter, and this is going to occur in patients who have normal fluid volume and or have a fluid volume deficit or excess. But usually what you see it in is a fluid volume deficit, and usually it's the people that are on extremes, the very young, the very old, because of their fluid status, and people that are cognitively impaired because they're not intaking appropriate volume. So you're looking at an excess of sodium, and you'll see that with heat stroke. You'll see that with diabetes insipidus, and you'll also could see that with certain hypertonic IV solutions. So in some situations, when patients have extremely low sodium levels, they may be administered something called 3% saline or 5%. It depends on what the facility protocols are, which is much larger than than your normal saline concentration. So subsequently, you have to monitor the sodium levels very, very closely in regards to that administration, because what you may be treating is what ultimately you may be causing something else. With hypernatremia, an individual could have thirst, could have an elevated temperature because of the loss of water. And what you need to do is that in order to lower the sodium level, you would need to obviously give hypotonic solutions. So half normal saline, give diuretics that are like a loop diuretic that would literally remove sodium. And then look at what your water losses are and how that's happening. And then look at, is the person taking too much intake of sodium? They eat too much salt related foods, and then you want to monitor CNS changes. So with hypernatremia, you have to worry about CNS depression. With hyponatremia, you have to worry about CNS irritability. And somebody whose sodium level drops below 125, you have to put them on seizure precautions until obviously you bring the sodium level up. Now, potassium. Potassium, the normal range is 3.5 to 5. But in the hospital setting, if you had a potassium level of 3.6, they'd supplement you up to 4.0. So that even though your books say the normal range is 3.5 to 5, in a clinical setting, you're going to see supplementation to bring that potassium level up to 4. Now, as we talked about, hypokalemia is most commonly associated with a metabolic alkalosis. So, so there you go. And causes of low potassium level could be that you're vomiting, that you have suctioning of your upper GI system, that you have a poor intake of potassium, and certain electrolytes may affect that potassium level as well. Now, a low potassium level is a cardiac irritant. So you're going, you're going to start to see cardiac arrhythmias. So especially with the cardiac patient, you're going to see that maintenance of a potassium level of about 4.0, all right? You may see dilute urine, excessive thirst, fatigue, and you may see certain decreased bowel motility to try to compensate for the loss and the creation of potassium and the creation of a metabolic alkalosis. So you're going to consider, as we mentioned earlier, potassium replacement. Remember that you replace potassium most efficiently parenterally through a central line. That central line administration is 10 milliequivalents over at no less than 30 minutes. And you never, ever, ever push potassium. And also with potassium, after you've given general protocols in most institutions, is that after the person receives 40 milliequivalents, you want to check to see what the potassium level is. And also remember that your kidneys, in terms of renal function, impact how well you're going to manage potassium. So that if you're in renal failure or you are approaching certain levels of renal failure, your supplementation of potassium has to be very carefully considered. Okay. If you give potassium IV peripherally, then you have to give it in a bigger volume of like 100 cc's and give it slowly. And also you can give potassium supplementation PO. Now, hyperkalemia is if you go above 5, and it usually occurs in patients in renal failure. And is it at a higher risk in older patients because older people, because of the fact that they have decreased renal function? And the reason cardiac arrest is associated with it is because, as I mentioned to you earlier, hypokalemia is related to cardiac irritability. So you have PVCs. Hyperkalemia is related to cardiac suppressant. And that if your potassium level is too high, you're going to go flatline. So with hyperkalemia, you'll see flatline. Hypokalemia, you would see, and we'll talk about later on in the course, you may see PVCs, cardiac dysrhythmias. Now, when somebody is going through open heart surgery, one of the things that they will utilize is a K bath, potassium bath. And what they do is that if the patient's going to be placed on the bypass machine, you have to stun the heart, because now the bypass machine is actually doing both your cardiovascular and, in a sense, respiratory component of oxygenation. So that the heart needs to be stunned so the surgeon can have access to it and do what needs to be corrected. So the K bath literally stuns and stops the heart. And then once the surgery is finished and they're taking the patient off of bypass, they shock the heart, stimulate it to then pump again. So that, patients that are in renal failure who may have a very high potassium level, like 7 or 8 or something in that range, you may see them come to you in cardiac arrest. And actually, this is the only patient population that I've ever seen, convert from flatline to a regular rhythm once that, emergently the potassium level is corrected. But you have to be really on top of the patient and literally correct it as it stops the heart. But cardiac, the asystole is not something that, you have a high success rate of regenerating function. So with hyperkalemia, you're looking at causes big one being renal failure, certain medications like, in regards to those diuretics that replace, sodium for potassium, but you don't pump it up too high, and there you go, and metabolic acidosis. So that you're going, you're not going to see dysrhythmias in the true sense of the word like you would see with PVCs. But what happens with the EKG complex is it kind of like just flattens out. As we'll talk about later, the PQRS and T kind of like stretch out and then go to the point of being flatline. And there you go. So that with hyperkalemia, you're going to look at your EKG. You're going to see initially what happens is you get peak T waves, which we'll once again talk about later on when we talk about EKG. You also want to make sure that you're limiting the intake of potassium. And then you could use what they call cation exchange resins, K-exolate. And K-exolate basically, you can take it PO, or a person can have an enema. And what happens with the K-exolate is it pulls the potassium towards it, and then you excrete it. So that if you don't have diarrhea, this is not going to be successful. All right. In terms of IV sodium bicarbonate, correcting the acidosis will also push the potassium back into the cell. Because remember that when you're acidotic, the hydrogen ions, the body works to correct the acidosis by pushing the hydrogen ions into the cell. And when you push it into the cell, you're pushing out the potassium. So that if you correct the acidosis, theoretically, those hydrogen ions will come out and push the potassium back into the cell. Also, in terms of other things that you might see used emergently, is 50% an AMPA D50, which is 50 cc's, and 10 units of regular insulin, IV push. And once again, the potassium will bind with the glucose, and now the insulin will carry it into the cell. Also, calcium gluconate, in terms of helping that migration, may also be administered as well. And dialysis will always correct hyperkalemia because of the fact that you're dialyzing the patient and you're correcting the metabolic acidosis accordingly. Now, calcium. Calcium in terms is generally looked at in milligrams per deciliter. So you're looking at a serum level that's less than 8.6, and you also have to look at what the albumin level is. So, you know, in terms of if you have a low albumin level, you'll have a higher free calcium as the albumin level goes up, because calcium binds with albumin. Calcium is controlled by your parathyroid hormone and calcitonin. And once again, we'll talk about that when we talk about endocrine. But remember that calcium is has a couple of functions. Well, obviously it's used to build bone, but it's also used in regards to muscle contraction. It brings the actin and the myosin together. That's part of that muscle fiber in order for it to contract. And then you're looking at it also as playing a very important role in regards to the clotting mechanism. Because if you don't have calcium, you do not have a clot. And there's a substance known as citrate, and citrate is used when blood is external to the body to prevent it from clotting. So that when you're receiving blood products, there's some citrate in there. So you have to watch closely what the calcium level is if the patient's getting a lot of blood transfusions, like 4 units of packed red blood cells. And really I should qualify it as when you're dealing with red cells, so either whole red cells. Because if you're giving clotting factors, that doesn't, you know, that's not an issue. But if you're giving red cells, you have to worry about the red cells external to the body in whole blood and in packed cells. So that citrate is added to those blood products. So after 4 sequential units of blood, I'm not talking like you got 4 units of blood over 5 days. I'm talking somebody's definitively bleeding out postoperatively or through trauma, so that you're giving 4 units of blood right after each other. So you have to think about also the calcium level. In terms of hypocalcemia, you're looking at, let me just check this. Okay, yeah. All right, so some causes would be hypoparathyroidism in terms of the control of your calcium levels. Alkalosis, I talked about blood transfusions, kidney disease, as well as looking at certain medications. A low potassium level will present with tetany. Remember Trousseau and Taussig sign, okay? And and that if you don't have good muscular control, you could also see seizures, and lack of muscle control could also represent itself through dyspnea and laryngospasm. And I talked to you about clotting. Administration is you can administer calcium gluconate. Calcium fluoride you may see in the clinical area, but if that's administered, that's like when the patient is really in like an pre-arrest type situation, and you're going to push calcium, that's what you're going to push, calcium chloride. But calcium gluconate is what you're going to supplement, and you'll supplement that IV over a half hour to an hour. Once again, the idea of seizure precautions, you look at oral calcium and vitamin D supplements. Remember, you need vitamin D in order for calcium to travel into the bloodstream. Exercise decreases bone calcium loss, and then obviously individuals need to be taught about diet and medications. And here's your Trousseau sign. When you pump up a blood pressure cuff, your hand goes into like a claw-like appearance. And then Chopstick sign, I thought I had both of them there. Chopstick sign is when you tap on the cheekbone, facial nerve, and you see twitching. High calcium levels or calcium levels greater than 10.2 milligrams per deciliter. Hypercalcemia in terms of present has a high mortality. You see that in malignancy because of the breakdown of tissue. You also see that because of bone loss related to immobility. And the opposite side of it is hyperparathyroidism, as well as certain diuretics, because now you're removing water and there's a higher concentration. Patient's going to present with muscle weakness. So the opposite, you're suppressing muscular function. Very bad nausea, constipation, diarrhea, in the sense that you're looking at GI movement of content, because of the idea that you're looking at your fluid imbalances. You may see dysrhythmias on your ECG, EKG. So now, in regards to hypercalcemia, you're going to treat the underlying cause. You're going to look to facilitating more of a presence of calcium, but remember, you always have to look at what the albumin level is, because if the albumin level is low, your calcium level is going to be, free calcium is going to be reflectively higher. And as you correct that albumin level, that protein, that calcium level will effectively be lower. Now, magnesium. Hypomagnesemia is when your serum level is less than 1.3 milligrams per deciliter. It's also associated with low potassium and a low calcium level. You'll also see Chopsticks and Trousseau signed. You'll see a depression of affect. You'll see neuromuscular irritability and EKG changes. Remember, you've had OB already, so you remember that a patient that suffers from hypomagnesemia is your eclamptic patient, or your pre-eclamp patient. And so that a low magnesium level is a CNS, central nervous system irritant, so that this patient could also present with seizures. Magnesium also plays a role in terms of your cardiac cycle. And there's a cardiac situation where if you go into a rhythm called VFib, ventricular fibrillation, one of the signs might be that you have a very, very low magnesium level. So after giving, the emergency drugs that you see normally, that maybe you might, that you would use normally, that you may see magnesium used as a third line, because it may be that that the magnesium level is low. So you're going to administer magnesium generally IV. You're also going to administer it 1 gram generally, also over 30 minutes to an hour. You can supplement it orally. It doesn't have the same, calcium and magnesium do not have the same irritability to peripheral access as does potassium, so that you can safely give magnesium and calcium as supplements accordingly. Remember that you have to also put the patient on seizure precautions. You have to worry about dysphagia because of, anywhere there's any kind of muscle tissue, that you could have problems accordingly. And then you have to monitor what the dietary intake is. Generally speaking, when you're looking at poor intake of calcium, poor intake of magnesium, and later when we talk about phosphate, generally it's because of very poor nutritional states. All right, so that, why it's associated with alcoholism is because people who generally have a high intake of alcohol are just taking in empty calories and not monitoring and supporting their true caloric needs, their true nutritional needs, rather. Hypermagnesinemia, you're looking at a level, greater than 3 milligrams per deciliter. There's, generally speaking, a high magnesium level is associated with renal failure. So just like you're concerned about, administration of potassium with patients in renal failure, if their potassium level is low, you're also concerned about it with regards to magnesium and some level calcium. So in regards to what also could cause it is extensive tissue loss, in looking at diabetic ketoacidosis because of the electrolyte shifts, and excessive administration of magnesium. Now, just as an aside, when we talk about asthma, one of the things I didn't mention to you is that if somebody has a really tight asthmatic acute presentation, one of the things that they might do is push up that magnesium level higher than than what you would. We'll push it up to the higher range, or maybe go a little bit above what's the acceptable higher range, in order to relax the the bronchioles in terms of the musculature that surrounds them, to relax the that bronchiole so that that spasm will stop. But once again, whenever you're bringing up somebody's magnesium level or administering magnesium, you have to monitor neural status. If you don't monitor, neural status, you could put them into coma. All right. So the point is that hypomagnesemia is also an irritant, in a sense, a CNS irritant causing seizures, and hypermagnesemia is a CNS depressant causing less awareness, neurostatus, and also it suppresses muscular activity. So that management of hypermagnesemia is to counter it with IV calcium, dialysis, avoid medications containing magnesium. We don't give acids like we used to, but Mylanta has a high amount of magnesium in it, so that if somebody has a problem, they're in renal failure, or has a problem in general managing magnesium, you're going to give them an antacid called Amphigel, right? So you want to give them something that does not have a lot of magnesium in it. Now, in terms of looking at hypophosphatemia, is considered a serum level below 2.5. And once again, you're looking at nutritional status. You're looking at people that, don't have the appropriate nutritional intake. And subsequently, you could look at certain endocrine disorders, but primarily you're looking at poor nutritional intake. With hypophosphatemia, you're going to see confusion, you're going to see muscle weakness. It presents like Guillain-Barré. It's not Guillain-Barré, which is a post-viral syndrome that has ascending muscle weakness. Well, hypophosphatemia presents also with that in terms of an ascending muscle weakness. So that replacement is going to incorporate usually it comes in either a sodium or potassium concentration combined with it. And obviously you'd have to know what the person's sodium and potassium levels are in terms of knowing what admixture it's going to come with. Usually most institutions, that's admixtured by pharmacy so that you're not mixing it. In terms of nursing management, you want to make sure that the person is eating appropriately. Even if you don't really eat well and you eat like potato chips, whatever, if something that you eat came from the ground, it's going to have phosphate in it. So even like the worst, kind of foods, junk foods as we call them colloquially, right? Very often they have a high phosphate level or an adequate phosphate level to maintain intake for you to be okay in regards to this. But in general, you're looking at a good nutritional status. Now, hyperphosphatemia is when your serum level is above 4.5, and you're looking at kidney disease. You're looking at once again endocrine disorder, and certain chemotherapeutic agents for cancer. Remember, chemotherapy, everybody thinks chemotherapy is a term used for cancer drugs, but the reality is chemotherapy means chemical therapy. So that, when you say chemotherapy and you read it in you'll read it in some of your articles, regarding different conditions, and they talk about chemotherapeutic agents, what they're talking about is medications. So that if you're going to be really specific to cancer drugs, you say oncologic chemotherapy. But in this case, we're talking about oncologic chemotherapy. In regards to, there's manifestations or, a few symptoms. You want to treat the underlying disorder in terms of, vitamin deficiencies, and you're basically going to make sure that the person doesn't eat a high phosphorus diet, and that you're teaching them how to eat appropriately, and that there's similar signs as associated with hypocalcemia, but not as deleterious in process. Now, in terms of looking at chloride, hypochloremia is when your serum level is less than 95 milliequivalents per liter. So you're looking at reduced chloride intake, GI loss, sweating, metabolic alkalosis, fever, burns, wherever there's a fluid loss, and also loss of other electrolytes that chloride hooks up to, like potassium and sodium. And with hypochloremia, you're going to see agitation, irritability, weakness. You'll also see the replacement of it through through things like normal saline or half normal saline. excuse me. And nursing management is once again to avoid free water, to encourage foods high in chloride, and patient teach appropriately. Excuse me. Excuse me. Hyperchloremia is when your serum level is above 107. When you have too much sodium chloride administered, when you're hypernatremic, when you're dehydrated, you know, all of those things that kind of go hand in hand with each other. Some of the manifestations could be tachypnea, lethargy. You could see hypertension, cognitive changes, and it plays a role in terms of your anion gap. Now, and remember, your anion gap is your sodium minus your chloride plus your CO2. And your medical management is going to be to restore electrolytes and your fluid balance. And you as the nurse are going to assess, you know, you're obviously look at what the lab values are. And remember, just as an aside, in terms of lab values, no matter where you work, lab values always should be relayed to the individual that ordered them. So in other words, you shouldn't take the lab value from the lab and then tell the doctor or the primary care provider. You need to refer that lab, which most people who work in the lab know, to the primary care provider, the physician, the nurse practitioner, or the PA. These grids are grids that are still used to this day, and you see them on charts in terms of reports. Excuse me. So the middle grid is when you're looking at electrolytes. So it's your sodium over your potassium, chloride over your CO2. Your CO2 actually reflects your bicarb on your blood gas. Then it's your BUN creatinine and your glucose. The upper left-hand corner is your CBC. Your upper right-hand corner is your coagulation. And then your bottom is really your liver profile. So that's it in terms of fluid and electrolytes. I just figured that it's important